Thank you, Dr. Matrana. Well, we have tried to take this and run with it because education is so important. As Dr. Jernigan alluded, our future is something we need to invest in. And so this is one way we can get future learners, such as medical students and residents, to invest in cancer care. So we took time to develop this, and hopefully we can develop even more. I also want to thank the committee. It wasn't just me. We formed a committee. We put out the advertisements. We read through tons of abstracts, and it was with their help that we were able to select it down. It was a very hard decision to select it down to the top three. I see Dr. Ellis is in the audience, and he's one of the committee members that was very dedicated to this. And if I'm missing anybody else, I apologize. But it was a true honor and a pleasure to work with the committee members to select the top three winners. And these are in no particular order. They will be announced at the crawfish boil tonight. So in no particular order, these are the top three abstracts that the committee has chosen. So I first want to bring up student from LSU, Gabriel Peterman, and this person is presenting cognitive gene expression analysis of pediatric patients treated with methotrexate.
So the topic of today's presentation, methotrexate and pediatric cancer. So what is methotrexate? Well, it is a chemotherapy drug. It works by inhibiting the growth of cancer cells by blocking the synthesis of the folate vitamin that they need to grow. It has been used very successfully in our treatment of pediatric osteosarcoma, and more importantly for today's presentation, acute lymphoblastic leukemia, with the latter actually possessing now an 85% to 95% pediatric survival rate in our patients. And this is very good, right? Because we want our patients to survive. However, that we have seen some long-lasting neurological side effects in some of our pediatric patients who have been treated with methotrexate. So we have prior studies, numerous, showing poor outcomes as these patients grow and go to school, and memory, intelligence, attention tests, they're just not performing as well as their peers. We also have other studies that have shown that white matter growth is declining in these patients. And our lab, in fact, has previously published findings at the Manning Family's Children's Hospital, previously known as the Children's Hospital in New Orleans, that some of these patients have developed profound hearing loss as they've aged. However, the exact mechanism that methotrexate is acting on to cause these neurological defects is currently unknown. Therefore, our lab is hypothesizing that methotrexate is perhaps deregulating the expression of some of the different genes related to healthy brain function, and that this may be coming from a gene-environment interaction with methotrexate that may demonstrate a correlation with these long-term effects. So the goals of this project were that we want to identify some candidate genes that might be at risk following methotrexate treatment. And we also want to reveal any genetic networks that may contribute to these methotrexate-induced late effects. So what we did here is that we screened different patient charts from the Manning Family's Children's Hospital who were treated with methotrexate. 70% of these patients were diagnosed with ALL, and we also excluded any patients who had any brain tumors or cranial radiation. We then collected white matter brain samples from the pathology department, along with age-matched controls. And then we isolated both their DNA and their RNA with the Covaris True Extract Total kit. So our first question is that we want to figure out if methotrexate was indeed affecting gene expression in these kids. And so as we all know that genes go from DNA to RNA to proteins, so we want to look to see at the different RNA levels to see and measure the gene expression in our tissue samples. And so we took our isolated RNA and we measured it using the NanoStrings nCounter neuroinflammation panel, which is a RNA microarray that targets over 770 genes associated with neural inflammation. And here are some of our results that we found. So we found two genes. Actually, we found numerous genes, but here are just two genes that I'm presenting here to you today. The GJA1 gene, it controls a gap protein, gap junction protein, that we found it was over 717% increased in these pediatric patients compared to controls. So that's a large difference. And prior studies have shown that upregulation in this gene has been associated with different memory disorders such as Alzheimer's disease. Also interesting for our hearing loss study that abnormal expression has been linked to hearing loss in the past. Another gene, GRM2, was down by 97%. And prior studies have shown in knockout mice that this has been related to impaired spatial working memory and pulsivity. Now, these are just two genes from our study. We do have many more. If you would like to learn more about those genes, we actually have a poster out. Believe it's the first one by the purple CAGLA flag out there. My friend Gabby Sheets is going to be presenting out there. She's my best friend. She's very cool. That's why I had to put her picture up in front of 50 people here this morning. So go look for her. She's very fun. Go ask her questions. Great time. All right, so now that we know that we are seeing an effect on gene expression in these methotrexate patients, but how is it exerting this mechanism? So that's what we want to figure out. So there are many different steps in the gene expression process that could possibly be regulated or affected by methotrexate. We have DNA methylation, histone methylation, RNA splicing, RNA transport, protein binding, once protein is made, enzymatic degradation. However, for our study, since we found that RNA was already abnormally expressed, we want to go back and look at the DNA, and more specifically DNA methylation. So what is DNA methylation for those who might not know? So essentially that we have found that different environmental factors can cause physical changes to our DNA by adding methyl groups at different cytosine sites right before the gene that controls how the gene can be expressed. Normally, these cytosines are bound to guanine in the DNA, and so we call these CPG sites. Methyl groups, they almost act like my little picture that I don't know if y'all have ever seen these spikes that prevent pigeons from landing on buildings. These are kind of how these methyl group spikes work. They prevent transcription factors from binding to the DNA and actually expressing the gene. And like I said, that these methyl groups, the more methylated a CPG site is, that it often suppresses the gene that's associated with. And so what we did is that we did a preliminary methylation analysis on our DNA that we collected with the Infinum Human Methylation Epic version 2 microarray at different targeted CPG sites, that we gave each CPG site a beta value to describe its average methylation. So each sample had a bunch of cells in it with a bunch of different DNA, and so the beta value corresponds to, so let's say here we have an example where the beta value was 33%. That means 33% of a particular CPG site was methylated in a specific sample group. So after we performed this analysis, we then linked each CPG site to its corresponding gene. And then we also have calculated the differential and relative beta value changes in the methotrexate patients compared to controls. And so generally, our results found that CPG sites were generally more methylated or methotrexate patients, but this methylation did not always correlate with RNA suppression. So what we did here is that we took our genes that we found were abnormally expressed in the RNA data, and then we found genes with increased CPG site methylation, and we took only the genes that had statistical significance of less than 0.001. And from that, we have 4 genes of interest that we're going to present to you here today. So here are our first 2 genes. As a reminder, DNA hypermethylation is associated with decreased gene expression. So our first gene we have here today, we have MSR1. we found 3 different sites that had increased methylation compared to controls, with the highest differential being about 7.94% more methylated in methotrexate patients compared to controls. And previous studies have correlated defects in this gene with Alzheimer's disease and schizophrenia. And we did, in fact, see that the RNA levels for this gene were decreased by 27% in our methotrexate patients. Another gene that was hypermethylated was BDNF, decreased by 6% in our methotrexate patient RNA group. It mediates plasticity for learning and has also been found to be reduced in Alzheimer's disease and Huntington's disease. TCIRG1 that decreases in this gene have been linked to osteopetrosis, which is a bone disease which causes bones to have increased density and abnormal growth. And it has been linked to compression of hearing nerves, which also correlates to our prior study finding hearing loss in our patients. And then our last gene we have to present to you, PSEN2, that it helps process amyloid protein in the brain. And so if it's defective, that it's been linked to Alzheimer's disease as well. So conclusions from our study. So RNA analysis has revealed that numerous neuroinflammation genes were abnormally expressed in our methotrexate patients compared to controls. And these genes were related to known psychological, neurocognitive, and autological clinical relationships. DNA analysis showed that CPG sites were generally more methylated in our methotrexate population compared to controls, though the role and degree of hypermethylation is questionable. We shared 4 different genes with you that had significantly reduced RNA expression and significantly increased DNA hypermethylation. This DNA methylation data is still ongoing. In fact, I think we got it like last week, just in the nick of time for this conference. However, other mechanisms from that big list I showed you of different process regulation mechanisms may also play a role. More specifically, methotrexate has been shown to induce histone acetylation, which may further explain some of the expression results that we've seen. So future directions for our lab. So we are going to do a prospective study at the Manning Families Children's Hospital Late Effects Clinic to follow up with some of these kids who have received methotrexate to check for any neurological and psychological autological symptoms that they might be having, and also looking at some of their socioeconomic backgrounds. That will be a follow-up of some retrospective studies our lab did, looking at hearing loss and also looking at area deprivation index for these patients. I would also advise to go look at Gabriel Sheet's poster today during lunch to learn more about that. We're going to continue to process our DNA methylation data, and we're also going to aim to replicate our real-life results with more controlled neuronal cell lines. And so I just want to end with this. With improvement in pediatric cancer survival rates, it's becoming more and more important that we increasingly investigate the late effects that we're seeing with some of our chemotherapy drugs, especially methotrexate, and possibly look at some mitigating factors that we can look at, such as adjusting methotrexate dosing guidelines. Our study results here indicate that early interventions and follow-up care should include auditory, medical, and neurocognitive assessments for some of our patients. And with that, here are references. And here's some special people we'd like to acknowledge. I have 2 other friends here, Keisha Patel, she's sitting right there in the middle. Also have to embarrass her this morning. They're going to be presenting another poster on cancer education right by Gabby's. Please go see theirs. It's awesome. Go bombard them with questions. And speaking with bombarding people with questions, does anybody have any for me I can try to answer?
Any questions?
Yes, sir. Very nice work. So I have a sort of a procedural and timing question. How did you get the white matter, and when did you get the white matter, and how did you get the control samples?
So we collected the white matter from Manning's Families Hospital that we had to collect this matter from patients who had passed away. So some of this, fortunately, pediatric patients don't pass away that often, but some of these samples were several years old. Some were new. We collected, believe we got this about our samples maybe two years ago, 1 year ago. And so there was great variability in our samples, but we had to work with what.
Is there an opportunity to do the neuroinflammatory studies from CSF without needing brain tissue?
I'm sorry, can I have you repeat your question?
So instead of using brain tissue, can you get neuroinflammatory markers from the CSF so you don't have to biopsy living brains? Because CSF is going to be much more accessible.
Yes, sir. I think it is a possibility that I think some prior studies we looked at, maybe it wasn't as, strongly expressed, so we wanted to go first with the actual tissue. But I think that's why we're kind of looking more at cell line, and perhaps we can be a bit more controlled with our expression and look more directly.
Thank you.
Thank you.
Okay. Thank you, Connor, for that presentation. Our next, thank you, Gabriel, for that presentation. Our next presenter is Connor Hartupee. I hope I said that correctly. Connor Hartupee from LSU, also a medical student, and this person is presenting on disparities in receiving non-surgical therapies impact outcomes in non-metastatic gastric cancer in Louisiana.
Good morning, CAGLA. It's an honor to be able to present up here, and I appreciate everyone for being able to listen in today. I would just like to note in the future, when they tell us we have a podium presentation, that we'd be doing in front of a larger audience than anticipated, and that the screens, I apologize in advance, some of the tables may have some numbers on them that I will read out loud, but they may be a little difficult to read, especially for people more claustrophobic. My name is Connor Hartupee. I'm a fourth-year medical student. I'm presenting today, as she said, on disparities in receiving non-surgical therapy impact outcomes in non-metastatic gastric cancer in Louisiana. So for some additional background in this, we're talking about gastric cancer, which is still common and one of the more high mortality rate cancers that affects a large portion of the population. And although the trends are improving, it's still one of those cancers that we have been making progress in. And as we've been making progress over the years, we can analyze using Louisiana Tumor Registry's demographic visualization tool, and as they were doing yesterday, it's a great way to see both parishes and state by stage, by race, and by sex, those that are highest mortality rates, those with highest incidence. And especially among African American males, we see a significantly increased incidence compared to national averages. It's 17 per 100,000 versus 15 per 100,000, so it's a 20% increase compared to the national average for African American males. And we still see, on top of that, we also have a slightly lower mortality or 5-year survival rate at 32.3% compared to 36% nationally. That number has been improving over time, and so it's good to see progress, but it's still important to look and see why we're lagging behind nationally. So for additional context, multimodal therapy has become the mainstay for gastric cancer. Surgery is curative treatment for resectable local disease in gastric cancer. It is still your primary choice when we have it. It is coming from research lab with surgical oncologists, so there may be some bias, but talking about it in the MAGIC trials and classic trials, we demonstrated survival benefits in perioperative chemotherapy and adjuvant chemotherapy. In these two groups, we're seeing increased survival both at R0 resection at time of surgery and perioperative, and adjuvant therapy for 5-year survival rates. So guideline recommendations are generally systemic therapy along with surgical resection when the availability and the patient is amenable to it. So in terms of inequities within Louisiana, Evidence suggests disparities in multimodal therapy use, particularly among minority populations, and access to care and treatment decisions may vary based on race, insurance status, and healthcare infrastructure. So this study in particular evaluates rates of definitive treatment, identifies inequities in access to and receipt of multimodal therapy, and assesses the impact of disparities on outcomes. Just some general aside. In terms of looking at progress over time, this graph represents the mortality rates of Louisiana versus the United States for gastric cancer. And as we can see over the last couple of decades, we've actually made significant strides in reducing mortality rates. We still lag behind nationally, but in order for recent advancements in next generation medicine to benefit the community and benefit the patients that we serve, we need to be able to do retrospective analyses like these in order to look back and see who's benefiting from the most, who's not benefiting at all, where are we leaving people behind. And so that's the major importance behind this kind of work. In terms of methods, this is coming from LTR database from 2010 to 2020. Patients were non-metastatic, primary invasive T2 to 4 or NET status with positive lymph nodes, those defined as surgically resectable disease. Patients less than 18 years old, gender non-binary, incomplete socioeconomic status, unknown treatment status were excluded. Non-surgical therapies were defined as having received any form of radiation, chemotherapy, or immunotherapy. And received non-surgical therapy was modeled using logistic regression. Overall survival was modeled using Cox proportional hazard models. Some additional statistical terminology, we're talking about odds ratios, adjusted odds ratios, rate ratios, and hazard ratios here. So for some additional context, odds ratios talking about the likelihood of a group receiving a therapy in reference to a standard demographic. Adjusted odds ratios including additional socioeconomic variables that may play a role. Rate ratios is talking about in this case, the rate at which a specific demographic is receiving those therapies compared to another group. Hazard ratios talking about the incidence and likelihood of an event, in this case, death or progression of disease between two groups. So getting into the results, and this is where I apologize for some of these numbers, we're looking at a population, or over the 10 years this case was done, we're looking at a population of 561 patients that had not resectable disease. And so among those, 91 patients did not receive any form of non-surgical therapy, and 200, my PI would be mad if I didn't mention it, but 211 patients did not receive surgery at all as well. Females were more likely than males to not receive non-surgical therapy, and 6.8% or 38 patients did not receive any therapy at all. We're talking about definitive treatment or treatment that is significantly prolongs life in this case. And yes, there are many asterisks that go with those that did not receive therapy, but looking at the numbers alone, we do see some differences. Looking at the odds ratio of patients that did not receive it, these are a little more visual numbers, but we see patients greater than 70 to 79, females and Black patients in particular, were receiving non-surgical therapy at rates less than their counterparts. So females were receiving it about roughly half, Black patients were also receiving it roughly half. And then after adjusting for additional socioeconomic factors, we actually see that the Black patient population loses significance, but that's also demonstrating to us that multiple socioeconomic factors like poverty, rurality, insurance status play a major role in their odds of receiving these therapies as well. Hispanic patients were also significantly less they were less likely. However, given the smaller number of these patients in the population, it was not found to be significant. In terms of time to treatment, we do see delays in patients in the both 60 to 69 age range, greater than 70, and those with Medicaid, Medicare, and other unknown insurance status had increased rates or decreased time to treatment compared to their counterparts. And it was marginally significant within Medicaid insurance. Medicare insurance, we do see significance. And then one thing that comes to mind and comes up is non-surgical therapy in particular does have a significant delay compared to those receiving surgery. As we can imagine, there is a little bit more data processing of patients' functional status, like evaluation for what kind of therapies they may be suitable for during that time. And so there's a little bit more of a lag time for those patients. Some additional results is looking at the overall survival of these patient groups. And what comes up importantly is Those that did receive surgery had a hazard ratio of 0.3, so they were a third as likely to succumb to disease compared to their counterparts that had no surgery. And those that received non-surgical therapy had a hazard ratio of 0.43 after adjusting compared to all other things. And so we do see pretty significant changes in survival benefits for those that receive non-surgical therapy and those that are receiving surgery. And the graphics on the right here demonstrate, on the right is surgery, and as you can see, the line in yellow is those not receiving surgical therapy or non-surgical therapy, and then the line in blue is demonstrating those not receiving non-surgical therapy. The double negatives is throwing me off, I apologize. But we see the median time to survival is roughly 34 months compared to 44 months in these groups versus no surgery. We see the median time to survival, obviously, for neither therapy is next to 0 months compared to those receiving non-surgical therapy is closer to 13 to 14 months. But just some conclusions from this: the significant number of patients did not receive any treatment modalities within this population. Older age Medicare and Medicaid recipients experienced delayed receipt of treatment compared to their counterparts. Receipt of curative surgical resection conferred significant survival benefits over non-recipients. Black patients and females were less likely to receive non-surgical modalities for gastric cancer in Louisiana, and socioeconomic backgrounds affect these rates of receiving such care. Improving long-term care and patient outcomes requires proactive support and identifying high-risk patients from these backgrounds. Some limitations within the study is that this is gastric adenocarcinoma data limited to the state of Louisiana, and specific treatment details are not available within the data set. Receipt of surgery and non-surgical therapy may depend on patient functional status, and evaluating patient functional status is something that is more complex than as simple as looking at their age, looking at their health, and gauging it from there. It's something that I think a lot of people can appreciate that it's done on a one-on-one basis, person to person. So these numbers do not represent individual functioning status, but it's just something to keep in mind. These are my sources and these disclosures and acknowledgements. These are contributors.
Okay, thank you, Connor. And now to our last abstract presenter. We have this presenter is from Tulane, also a medical student, Siva Paladugu. I hope I said that correctly. I apologize. This person is presenting therapeutic outcomes and safety of radiofrequency ablation for primary papillary thyroid carcinoma, a game-changing meta-analysis.
Hello, everyone. Thank you all for being here today. My name is Siva Paladugu. I'm a first-year medical student at Tulane, and I'm here to present a meta-analysis study, therapeutic outcomes and safety of radiofrequency ablation for primary papillary thyroid cancer. So let's get started. In 2020, there were nearly 600,000 cases of thyroid cancer, making it the 10th most common cancer and the most common endocrine cancer in the world. The incidence of thyroid cancer in general has been on the rise for over the past few decades, primarily because of increased diagnosis of small early-stage papillary thyroid cancers, or PTC for short. The PTC is the most common thyroid cancer, accounting for 85% of all thyroid cancer cases. And this increased diagnosis of PTC is largely due to advances in medical diagnostic imaging with greater sensitivities, such as high-resolution neck ultrasounds. Patients with PTC tumors usually have excellent long-term survival rates, which has led from a shift from total thyroidectomy to a more gland-preserving lobectomy. And because of this, minimally invasive procedures like radiofrequency ablation, or RFA for short, are taking precedence over open surgery techniques in order to preserve thyroid function and to negate, again, the need for open surgery. And RFA, for those that don't know, it's a minimally invasive technique that uses radio waves to generate heat to target and destroy the tissue of interest, and in this case, the PTC tumors. First, I guess, to our rationale and objective for the study. In recent years, many papers have reported promising short and intermediate term long outcomes for RFA, including significant tumor volume reduction, lower recurrence risk, and minimal scarring. The existing studies on RFA for thyroid cancer have several limitations, however, such as small sample size, limited data, variability in ablation techniques, and also previously published meta-analyses have included duplicate patient cohorts from single-center studies conducted by the same research groups and inevitably introducing bias to some degree. So our study objective for this project was to compare the outcomes of RFA when treating primary T1A versus T1B PTC tumors via systematic review and meta-analysis. In T1A, T1A tumors are classified as tumors less than 1 centimeter in diameter, and T1B tumors are classified as greater than 1, but less than 2 centimeters in diameter. So those are the two tumors that I'm going to be talking about today. Our methods, our systematic review and meta-analysis was conducted according to preferred reporting items for systematic reviews and meta-analysis, or PRISMA guidelines. We mainly searched databases like Web of Science, Scopus, PubMed, and ScienceDirect. Our inclusion criteria was studies dealing with T1A or T1B PTC tumors, treatment that was done using RFA, and no metastases. Studies focusing on the other thyroid cancer types like follicular or medullary carcinomas, or studies with insufficient outcome data were excluded. And in total, we found 805 potential studies, and our search criteria narrowed it down to 20 studies from 2008 to 2021, with a total of 6,613 tumors. The average age for a patient in these studies was 44 years old, with 79% of them being female. It's not really surprising that most of them were female, because from the literature, we found that PTC tumors are more prevalent in the female population. So now onto some graphs. I know this might look a little confusing for those of you who haven't seen a forest plot before. It definitely did for me when I first saw it. So I'll kind of help guide you along here. But from what we found in our meta-analysis of the 20 studies, we did some statistical algorithms, and eventually we found that the average tumor diameter within these 20 studies before the RFA was 0.69 centimeters. And again, T1A tumors are anything less than 1 centimeter. So because the average is below that 1 centimeter threshold, most of the tumors fall into that category. And you can see down at the bottom in the red box, the 0.69. The follow-up intervals varied for all of the studies, but most had something along the lines of 1 month, then 3 months, then 6 months, then 12 months, and so on. But the mean last follow-up time was 36.4 months, meaning that patients' data was taken for about 3 years in all these studies. So after extracting the data and running it through our meta-analysis software, we found that tumor disappearance rate after RFA to be 96.1% in the T1A subgroup and 76.7% in the T1B subgroup, with the overall weighted disappearance rate coming out to be 94.3%. Now, what exactly does this tumor disappearance even mean? It means that there were no residual tumor tissue found at the site where the PTC nodule was treated. This is not just a decrease in size, but a total loss of any detectable lesion. So on that last follow-up, around the 36-month time, again, on average, 36 months, the imaging came out to be negative for any residual tumors. For the tumors that didn't completely disappear, we noted a 99.4% reduction in tumor volume, not shown in this figure, but still quite impressive. There was a 1.1 tumor progression rate in the T1A subgroup and a 4.2 tumor progression rate in the T1B subgroup, and we define tumor progression rate as the proportion of cases where the treated tumor either increases in size, showed regrowth, or where new malignant lesions appeared in the ablated area after RFA. New cancer after RFA, we saw a 0.65% rate of new cancer in the T1A subgroup and a 2.4% rate of new cancer in the T1B subgroup. And what we mean here by new cancer is that there's a development of new distinct cancerous nodules in the thyroid that was not part of the original tumor or treatment site after the initial RFA. The overall complication rate for these RFA procedures was 1.7%, with transient voice change and neck pain being the two most common complications. In almost all of these cases, these issues were eventually resolved over time, and there were no major complications or deaths, so that's always really good to hear. Okay, but why? Why is this important? Why am I here? Why are you listening to me? What's for lunch? What's the point? And I will get to that. So the RFA has been shown to be a safe and effective, minimally invasive procedure. As the data suggests that I've shown here today, there's a high tumor disappearance rate combined with the fact that there is a low recurrence and complication risk. Instead of patients having to undergo open surgery of the neck, which leads to more scarring, longer hospital stays, more complications, longer recovery times, all of that can be avoided with safer and efficient patient RFA procedure. So RFA may be a viable alternative for surgery in select low-risk PTC patients. And lastly, I want to acknowledge THICA in partnership with ATA, who provided support for our project, and also the Tulane School of Medicine pilot grant for funding our research. Special thanks to Dr. Taraya and Dr. Candle for their mentorship and all their help throughout the process. And I also want to thank the Department of Surgery and all the hard work of my fellow co-authors who helped bring this project to fruition. Thank you. And I'll take any questions. Oh, yes. What was that, sorry? Oh, no, this is a procedure that is has been done worldwide. This is not just at Tulane. Usually, so according to the studies that we've seen, usually between 2 and 4 weeks, those kind of temporary changes subside. There were some like longer term complications with some, but yeah, mostly 2 and 4 weeks is max. Yeah. Oh, yes. Mm-hmm.
Do you think RFA will become the standard of care, and what do you think is limiting it? Is it access because of the equipment? What do you think in terms of the features?
Maybe it's a little bit of lack of awareness that the RFA is like just maybe as effective as open surgery, and also like I said, there's longer hospital stays. There's more incentive for the RFA procedure. You're getting really good results. And you're getting in the hospital or whatever is having to pay less money to keep the patient in the hospital. So it's a win-win situation for both the patients and the hospital and the doctors. So maybe that's how it's going to move towards in the future.